In this unit, we will cover meaningful use as defined by CMS, the Centers for Medicare and Medicaid Services, and explore the ideas behind the concept and the application of it within the physician's office workflow. The important thing to remember about meaningful use is that it is not just using EHR software, but using it in a way that improves individual quality of care and, ultimately, public health outcomes. There are a number of initiatives created by the American Recovery and Reinvestment Act of 2009, also known as ARRA, to provide incentives to adopt EHRs, including the High-Tech Act, Health Information for Technology for Economic and Clinical Health, the Meaningful Use Incentive Payment Program administered by CMS, the Centers for Medicare and Medicaid Services. A broad range of healthcare providers are eligible to receive these incentives. ARRA has also funded many regional and state initiatives to support and promote EHR technology and related best practices. Under the High-Tech Act, the Secretary of Health and Human Services reviews and approves ONC endorsements and collaborates with CMS in the rulemaking process. CMS drafted the proposed rule on meaningful use, accepted comments on the proposed rule, and then conferred with ONC and HHS in formulating the final rule. CMS also administers the meaningful use incentive payments. ONC drafted a separate standards rule and reviewed recommendations for the proposed meaningful use rule and decided on which recommendations to endorse. The HIT Committee, which reports to ONC, recommends policies relating to a national HIT infrastructure and recommends priorities for developing, harmonizing, and recognizing standards, specifications, and certification criteria. In collaboration with the HIT Committee, the HIT Standards Committee recommends standards, implementation specifications, and certification criteria for the electronic exchange and use of health information. The National Institute of Standards and Technology, NIST, tests the standards recommended by the HIT Standards Committee and creates a conformance testing infrastructure. Under the High-Tech Act, the Secretary of Health and Human Services reviews and approves ONC endorsements and collaborates with CMS in the rulemaking process. The HIT Committee, which reports to ONC, recommends policies relating to a national HIT infrastructure and recommends priorities for developing, harmonizing, and recognizing standards, specifications, and certification criteria. In collaboration with the HIT Committee, the HIT Standards Committee recommends standards, implementation specifications, and certification criteria for the electronic exchange and use of health information. The National Institute of Standards and Technology, NIST, tests the standards recommended by the HIT Standards Committee and creates a conformance testing infrastructure. The final rule defined specific requirements of eligible professionals and eligible hospitals to qualify for receiving incentive payments in Stage 1 of meaningful use. It also defined payment years, reporting periods, incentive payment amounts, and other program requirements. In the interim final rule, an initial set of standards were adopted for the implementation, specifications, and certification criteria of EHRs. In the final rule of 864 pages, 15 core and 10 menu requirements are specified, which providers must meet in order to achieve meaningful use and receive incentive payments. CMS envisions meaningful use as enabling significant and measurable improvements in population health through a transformed healthcare delivery system with these goals: improving quality, safety, and efficacy, engaging patients and their families, improving care coordination, improving population and public health, reducing disparities, and ensuring privacy and security protections. By 2011, CMS envisions data being captured and shared through lab results delivery, e-prescribing, claims processing, eligibility verification, and some quality and immunization reporting, which impact the national healthcare infrastructure by increasing the volume of transactions most commonly occurring today. By 2013, the focus will shift to advanced care decision support through registry and public health reporting, electronic ordering, home monitoring, continuity of care and PHRs, which will allow data to be aggregated and applied and will substantially accelerate data exchange. By 2015, there should be improved outcomes through accessing comprehensive data, experience of care reporting, and medical device interoperability, which will impact clinical management and performance improvement by promoting routine and regular data exchange. CMS envisions meaningful use as enabling significant and measurable improvements in population health through a transformed healthcare delivery system with these goals: improving quality, safety, and efficacy, engaging patients and their families, improving care coordination, improving population and public health, reducing disparities, and ensuring privacy and security protections. By 2013, the focus will shift to advanced care decision support through registry and public health reporting, electronic ordering, home monitoring, continuity of care and PHRs, which will allow data to be aggregated and applied and will substantially accelerate data exchange. Within the short time frame available under the HITECH Act, the spirit of the final rule has been to balance competing considerations, such as ensuring reform of healthcare and improved healthcare quality, promoting widespread adoption of EHRs, promoting innovation, avoiding and reducing excessive or unnecessary administrative burdens on healthcare providers. The final rule defines meaningful use as using EHR technology in a way that makes a difference in the quality of care provided, including the use of e-prescribing, the electronic exchange of health information to promote coordination of care, the reporting of increasingly robust clinical quality measures. Here are some useful things to keep in mind regarding meaningful use. According to the final rule, an eligible professional may receive EHR incentive payments under either the Medicare or Medicaid options, but not both. For the Medicare option, an eligible professional must be an MD, DO, dentist, podiatrist, optometrist, or chiropractor. A provider is not eligible if more than 90% of the care is in an inpatient or emergency room setting. Physician assistants and nurse practitioners do not qualify as eligible professionals under Medicare, but they do under Medicaid. Physician assistants can only qualify as an eligible professional under Medicaid if they practice in a rural health center or in a federally qualified health center, also known as FQHC. Medicare incentive payments are calculated only at the level of the individual provider. The final rule requires eligible professionals to demonstrate meaningful use in more than 50% of their clinical encounters. Under Medicare, eligible professionals cannot collect both e-prescribing incentives and EHR meaningful use incentives. They must choose one or the other. A payment year is defined as any calendar year, with 2011 as the first. 2014 is the last year an eligible provider can begin adopting an EHR system to receive any level of incentive payment, with the last incentive payments in 2017. The definition of an eligible professional in the EHR Meaningful Incentive Program differs for the Medicare and Medicaid options. Under Medicare, there are 6 types of providers that qualify as eligible professionals: MDs, doctors of osteopathy, dentists, podiatrists, optometrists, and chiropractors. The Medicaid option shares the first 3 as the Medicare option, that is, MDs, DOs, and dentists, but add 3 other provider types that are not under Medicare: nurse practitioners, certified nurse midwives, and physician assistants practicing in an FQHC or rural health center. Under the Medicare option, eligible professionals can receive a possible total of $44,000 if they adopt in the first 2 years of the program, 2011 or 2012. If they adopt in the 3rd or 4th years, the possible total incentive payments are reduced to $39,000 for those adopting in 2013 and to $24,000 for 2014, which is meant to encourage providers to adopt earlier rather than later and so avoid being penalized. All Medicare providers who do not adopt an EHR and meet meaningful use by 2015 will be penalized 1% in the Medicare fee schedule, 2% by 2016, and 3% by and after 2017. The possible total payments are limited to 75% of the eligible professionals' allowable Medicare charges. So, for example, to receive the full incentive payment of $18,000 in the 2011 payment year, a provider would have to have at least $24,000 annual allowable Medicare charges, since $18,000 is 75% of $24,000. Under Medicare, payments are made over 5 years for the first 2 years of adoption, then 4 and 3 years for the 3rd and 4th years of adoption, respectively, with 2016 as the last payment year for all adoption years. The total possible incentive payments decline each year over the course of the program. For those adopting in the first 2 years, the total possible incentive payment for each year starts with $18,000, then becomes $12,000, $8,000, $4,000, and $2,000 for each of the following payment years. The requirements for receiving meaningful use incentive payments progresses through 3 stages. Stage 1, capturing and sharing data, begins in 2011. Stage 2, advanced care processes with decision support, begins in 2013, and Stage 3, improved outcomes, begins in 2015. The vision of the policymakers for Stage 1 of meaningful use is to enable significant and measurable improvements in population health through a transformed healthcare delivery system, to improve quality, safety, and efficiency, and to reduce health disparities. Aligning with this vision, the priorities for Stage 1 are providing access to comprehensive patient health data for the patient's healthcare team, using evidence-based order sets and CPOE, computerized physician order entry, applying clinical decision support at the point of care, generating lists of patients who need care and using them to reach out to these patients, also known as panel management, and reporting information for quality improvement and public health outcomes.